Hey everyone, thanks for joining me in session 262 of the Behavioral Observations podcast. Dr. Pat Friman returns to discuss the behavior analytic approaches he uses with patients in the therapeutic setting. In this episode, we harken way back to session 16 and review some of what we know about anxiety and depression, which are the most common forms of mental health distress. In this episode, Pat talks about how he conceptualizes these challenges, what he does in the first session with patients, his general approach to treatment, the role of medications, his view on when to begin or cease therapy, the role of extinction, behavioral pediatrics, important therapist characteristics like kindness, compassion, and acceptance, and lots more. I could have asked Pat a lot more follow-up questions, and he had to go. So if this is something that you want to hear more about, go to the show notes for this episode over at behavioralobservations.com and leave a comment. Also, if you'd like to get a CEU for this episode or for over 50 other episodes, go to behavioralobservations.com/get CEUs to learn more. And while we're at it, I want to let you know that we're brought to you by the behavioraltoolbox.com, where Anika Costa and Dr. Paulie Gavoni and I have put together 2 online courses for school-based practitioners. If you haven't been to the website in a bit, I'd encourage you to go visit it again because we recently published our latest course, When Not to FBA, 5 Quick Strategies for Improving Behavior in the Classroom. As with our first course, Ready, Set, Consult, we've gotten great feedback on When Not to FBA. So again, if you work in public schools, please consider checking it out. Lastly, this episode is brought to you by Behavior University, where their mission is to provide university-quality instruction for the busy behavior analyst. Check out their webinars, on-demand events, RBT trainings, and supervises courses over at behavioruniversity.com. And don't forget to use the promo code PODCAST to save at checkout. That's it for opening remarks. So without any further delay, let's get to this really fun and informative conversation with Dr. Pat Friman.
Welcome to the Behavioral Observations podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Dr. Pat Friman, it's good to see you again. Thanks for coming back on Behavioral Observations.
Good to see you, Matt. And thanks for inviting me on, by the way. I really appreciate it. The show's pretty popular. Always glad to be part.
I appreciate that. Your episodes are fan favorites. So there's, when you look and see how many have been downloaded and things like that, there's some number of guests that are always clustered towards the top, and people really enjoy when you come on the show to share your thoughts on whatever the topic happens to be. On
your show, there's popular, and then there's Greg Hanley.
That's right. We're all just playing catching up, right? So one of the first, I think it was the second time you came on the show. I'm not sure if you remember this or not, because the show, believe it or not, it's been on the air for 8 years. I can't believe that, but I think it was episode 16. You'd come on and kind of gave, I guess what I would say is kind of like a mental health 101. I thought it'd be fun to kind of return to that. I guess fun in air quote, depending. I guess you probably reframe what I consider fun, but anyway. But the topic of mental health and therapy and things like that, it's one of those things that I think you encounter quite a bit in the popular culture, and certainly someone working in schools, there's a lot of focus on mental health resources and things like that. So I thought it'd be a good idea to revisit this topic with you because, of course, for listeners that are not familiar with you, you do a lot of clinical training with psychologists who are going out in the world, particularly working with kids. And again, I thought it would be a good idea to just talk about the role of psychotherapy and just kind of ask some what I consider maybe some silly questions or what have you. But the idea being that people have a good idea of what psychotherapy is, what it isn't, what it can help with, and what are some things to think about. So that's the context for this particular episode. So I guess let's start with this. What are some of the most common challenges that people enter therapy to deal with?
Well, there is the most common challenge, and it trumps just about all of the rest. And it's anything related to what's called anxiety. In the typically developing population, about 30% of all typically developing adults in the United States will seek services for anxiety one time or another. And in the autism spectrum population, it goes as high as 40 or 45%. In that population, anything that achieves a 50% prevalence is normal, statistically speaking. So it's an anxious world we're living in. But the thing is, a human being is a fearful being. And the things we're afraid of are kind of hidden from view. One of them is showing ourselves in the world. We're a member of the mammalian species, but we're the only member of that species that covers our body so the world can't see what it actually looks like. Why are we doing that? It's not for warmth. It's fear of being seen. And it's so prevalent that people aren't even aware of it being a fear. In fact, it goes the other way. If you don't wear clothes, you could get yourself into a lot of trouble. But that became institutionalized somewhere along the way. Initially, humans wore clothes for warmth. But at some point, they began to wear clothes because of modesty. And modesty is, I guess people think of it as a virtue. But in many respects, it's a virtue that has a central component, which is social fear. So we're a fearful species. We're afraid of everything. And it's worked for us to be so cautious and concerned and future-oriented. So it's not necessarily a clinical concern. It becomes a clinical concern when the word excessive is attached to it. So having the symptoms of anxiety does not mean you have an anxiety disorder. Having the symptoms of anxiety to the degree that they disorder your life in some way means you have an anxiety disorder. So a lot of people are thinking, "Oh, there's something wrong with me because I'm feeling anxious." No, that's almost the same as saying I'm feeling human. And it doesn't mean that they have a clinical problem. But if there's a bunch of stuff that they can't do or do in order to either avoid or get away from feelings of anxiety, and those things are impairing their life in some way, diminishing the size of their life, diminishing the quality of life, then it starts to border on clinical. So being afraid to fly, well, welcome to the club. Being so afraid to fly that you won't get on an airplane, that's different. Being afraid of public speaking, well, welcome to the club. But being so afraid of public speaking that you'll never, under any circumstances, do it, that's a different story. So things related to anxiety are probably the fundamental concern. And it's an anxious world now. People, more than ever in the history of our species, are paying attention to the news because it's so easy to pay attention to. It's everywhere. And the people that years ago, I would have said, report the news. Now I would say, create the news. People that create the news specialize in scaring people or making them mad. And for whatever reason, we're a species that likes to be scared or likes to be made angry. So we're tuning in to get that information, and it's having an effect on all of us. You don't have to talk with very many people to have them say, geez, the world today, it's never been worse. Everything's going to hell in a handcart. I don't know if I agree with that. I think it's always been a problem. People have always been at each other's throats. There's always been divisions. It's just that the news and the media puts us in closer touch with that kind of thing. And so people feel like it's more prevalent than maybe it has been historically and closer to home than they actually believed. So the biggest problem in clinical practice is something related to anxiety. Then next, the cousin to that is depression.
I see. Before we move to depression, I just want to ask a few follow-up questions about anxiety. Firstly, I missed that first statistic for the non-ASD population. About what percent of people will seek treatment for anxiety?
29 to 30%.
Holy smokes. Okay. And the examples you mentioned about fears, of getting on a plane, fears of public speaking, et cetera, seem kind of situational. Is it, and I'm also familiar with conditions that, you might consider more, generalized anxiety disorder. Is that a clinical distinction? In other words, are people, are there, can you talk about maybe different ranges of anxiety that people might experience the distinction might be, and I don't know, this is me as a layperson, not being a trained psychotherapist, just wondering if there's a degree of difference between someone who can get on with their life and do what they need to do, et cetera, but won't get on a plane versus someone who is fearful on a more continuous basis.
Well, there is a condition called generalized anxiety disorder. People that have that are afraid of a very large number of things and a very large number of experiences. And they gradually design their life to avoid those things and avoid those experiences. And the ultimate manifestation of that is what you might call agoraphobia, where a person just becomes housebound. They won't even leave their home. And you want to think about it traditionally, and we tend to think there's something off about that person. And maybe they have something akin to a disease process that's causing that extensive fear. Well, the science behind psychiatry, especially biological psychiatry, has invested millions, maybe billions of dollars searching for some kind of organic location for any and all of the conditions in the DSM, the Diagnostic and Statistical Manual for the American Psychiatric Association. But they still haven't found anything. They found correlates, but they haven't found locations. But it's almost axiomatic that there's something organic there, but we're waiting for them to find it. So we have a more parsimonious way of explaining something like that, explaining agoraphobia or generalized anxiety disorder. Let's just say a person has a predisposition to being a little bit apprehensive. And I do believe that's genetic. There's some people are predisposed to being laid back. Some people are predisposed to be more worried. And they have like a panic attack or they have a serious episode involving anxiety. Well, then they're subject to what we would call stimulus generalization. So anything that sounds like, looks like, tastes like, feels like, or smells like the thing can end up in the category. And so they started avoiding that stuff. Then you throw in derived. If you've ever been in a presentation by Steve Hayes where he'd ask the audience, name something, anything, just shout it out. They shout out something like rocking chair. And then he'll say to the audience, okay, name something that's not that. Is as different from that as it could possibly be. Beach ball. Okay, how are they alike? And then for a few minutes, or not minutes, but maybe a minute, the audience is quiet. And then in the next several minutes, they come up with about 30 ways the two things are alike. They're made alike through language. That's the power of derived relational responding. So like a beach ball and rocking chair, they're both words, they're both objects, they're both subject to gravity, they're both composed of letters, they're both invented by human beings. I could go on and on here. So you throw those things together, and the category of stuff that the person is apprehensive about and wants to avoid grows and grows and grows until they won't go out the front door. There's nothing organic about that. It's a natural human tendency to generalize, and it's a natural human tendency to use language to expand the generalization category. And if the central component of that category is fear, then it can end up being a generalized operant that has avoidance of just about everything in it, generating negative reinforcement or relief or whatever goes along with not having the apprehensive feeling that people don't want to have. Now, I have to ask, does that make sense?
Yeah, that's a helpful distinction. So I think that, again, addresses the, I guess I'm curious, of that huge swath of people who are seeking treatment for anxiety. Would you say that, do you have any sense of what proportion of those people have a more generalized condition versus something very situation specific, like a phobia or something like that?
Well, those are opposite ends of a continuum. A specific phobia on one end, and it's isolated to that object or possibly that experience. And then generalized anxiety is on the other end of the continuum. And then actually that's the shape of that curve is basically the shape of anxiety itself. So that extreme end is more rare, I suppose. So I'm trying to think how many clients I have that I think would fit that category. And it's a small number, but I have a large number of anxious clients.
Regardless of your title, if you are a behavior consultant who is working in or with schools and you are struggling and wondering why your interventions are not producing the desired results, you are not alone. Unfortunately, those tasked with improving behavior in schools are too often left to carry the burden by themselves. You are the behavior person, so you take care of it, is the unsaid mantra. But you can't improve behavior and the associated outcomes by yourself. In fact, creating sustainable improvement in student behavior almost always requires changes in the performance of the educators. I'm Dr. Paulie, and along with my colleagues Anika Costa and Matt Sikoria, we are designing coursework called the Behavioral Toolbox. In it, you will be taught strategies grounded in organizational behavior management for consulting in schools in a way that brings out the best in educators so they can bring out the best in the students they serve. If this sounds exciting, be sure to click on the link in the description to sign up for more information.
Okay, so if I'm understanding you correctly, is this something that's perhaps normally distributed where most people have some apprehension about a handful of circumstances, and very few people have something like agoraphobia, and very few people have like a very, very specific type of fear, and other than that, they're functioning perfectly fine.
Yeah, or as well as can be expected, ceteris paribus, as long as everything else is fine.
Sure.
But there's a way that people talk about anxiety that I have to correct in order to point them in the right direction.
Okay.
They say they have it. They don't have it. It's not like the measles. You don't have it. You're doing things that generate the apprehensive feeling. It doesn't just descend upon a person like an illness or like a cold I have now. I have a cold. And I am afraid, but being afraid, like if we were to substitute the word fear for anxiety, because that's what it is. Anxiety is just fear of stuff that won't hurt you. That's all it is. You substitute the word fear, would people continue to say, I have fear? No, I am afraid. Yes, I am anxious. That would be a better way to say it. They talk about it in a way that the mental health industry has convinced them to talk about it, which is they have it like an illness. They don't have it like an illness. That's all kind of down to Freud when he foisted the concept of psychopathology on the masses. So people, because it sort of mimics medicine, which is what he tried to do. He was a physician, and so I don't know if you want me to go down this road, but Freud was a neurologist. He was a physician. He works with a construct called pathophysiology. The physiology is your body. The path is where the illness is. You do an examination. You find a lesion. You find an infection. You find a tumor. And you go, oh, that's your problem. He has these patients that come in. They got a lot of complaints. He examines them. He doesn't find anything in their physiology. This is a smart guy, Freud. So he invents a body other than the body, made of different stuff than the body, borrows from the Greeks, and calls it the psyche. And then he gives it a little architecture: id, ego, superego, subprocesses, thanatos, eros, cathexis. And then he goes, that's where your pathology is. It's in the psyche. And thus was born psychopathology. It's just that the psyche doesn't exist anywhere. And that pathology doesn't exist anywhere other than language. But he was so persuasive that people began to think like, yeah, I have psychopathology, or people have psychopathology. How could you? You can't have it. But that's how people talk about depression. That's how people talk about anxiety. And so now they need a cure of some sort. If they look at it from a different perspective, that it's a function of stuff they're doing or not doing, they don't need a cure. They just need to do or not do stuff differently. So the people that come to see me get that message. It's a hard sell sometimes, but I'm pretty persuasive. And the results of following my advice usually are fairly evident fairly quickly. So usually get people to recognize that the way the society thinks about anxiety or depression isn't exactly the most beneficial way for them to think about it. And oh, by the way, Matt, I don't do psychotherapy. I mean, according to the insurance companies, I do. But therapy implies illness. The people I see are not ill. I don't think in terms of pathology. I think in terms of skill deficits. And you could fit that into any one of the things that are in the DSM. So I'm trying to promote skill development in all of my clients so they become more effective at contending with whatever it is in their world that has them apprehensive or avoidant or upset or sad unnecessarily, or what you might call depressed.
That's an empowering perspective. I like that. And I was actually going to save this question for later, but I think this is as good as time as any to talk about this, because one of the things I'm seeing a lot is people, putting their mental health diagnoses in their social media bios. It's kind of something I'm seeing that's new. Someone will put in, their bio that I've got, it'll say, and sometimes these people are like clinical folk, whether they're BCBAs, psychologists, whatever. They'll say, such and such, and then it'll be like a list of the alphabet soup. I have ADHD. I've got this. I've got that. Blah 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 blah. And I'm, I guess based off of what you just talked about, I can probably anticipate your reaction to that. But from my way of thinking, I'm not sure. I'm curious to what extent you feel that's something that's healthy or not, because again, it implies that I have the thing, as and this thing is localized in my head versus it being a problem of repertoire.
Right.
What are your thoughts on that?
Well, if you have a condition, then your story is, I have this condition. That story is based on some things that you're doing in the world that are questionable in some way, either by you or by other people. And then this thing that you have is the basis for those things that you're doing that are questionable. And so you can get a pass for that. People know, oh, I get it. You're agoraphobic. That's why you won't go out with me. As opposed to, you haven't mastered being out in the world while you're afraid yet. That's the direction I would go. But that puts the onus of effort on them to develop that skill, where if they want to declare themselves to have this, that, or the other condition, and they tell the world that, and they're doing that so that the world will understand that their limitations, whatever they happen to be, are a function of that condition that they have. And I'm fine with that. I mean, they're not working with me. I'm only concerned about the people that come in that door right behind me, that trying to foist any kind of therapy upon the world. The world is the world. If people live the way they want to live, that's all fine with me. But if you happen to be my client, then I'm very quick to let people know how I think, perspective I'm going to take. And if they're willing to work with a guy that has that perspective and takes that tack on things, then we can work together. And if they insist on being ill, I'm not the right guy. Now, I haven't had anybody insist on being ill for a long, long time. When you said the word empowering, I think that people that work with me get empowered. And we're giving them a different perspective on a condition that they think they have, which to me is a repertoire that they've been exhibiting or not exhibiting over a long period of time. And now they have another option that has more flexibility in it, more freedom in it, more possibility in it. And when you start mounting those things together in human life, it becomes much more livable, much more satisfying.
Hey everyone, I want to take a quick break here and thank our sponsor, Behavior University. And you're usually hearing me talk about their webinars, which you should definitely check out. But I want to draw your attention to a couple other things that they had to offer that I don't talk about perhaps as frequently as I should, and that's their 40-hour RBT training. They've got a couple of different tiers of products, so it's individualized to fit your budget, and they also have some group discounts for school districts if you're looking to train a whole host of individuals. So I would check out behavioruniversity.com and just click on the RBT 40-hour training at the top of the menu. They also have a great 8-hour supervisor training as well. And I think that I did the math on it. I think it's like $8.50 per CEU. I think it's like a 9-hour CEU course. And that gives you the tools that you need to improve your supervisory skills and to, in a technical sense, qualify to be a supervisor, I suppose. So again, those are two things that I don't talk about as often as I should. That's the RBT trainings and the 8-hour supervisor trainings. They're over at behavioruniversity.com. And whenever you're on that site and you see something that you're adding to your cart, use the promo code podcast to save at checkout. Again, that's behavioruniversity.com. And thanks, folks, for sponsoring this episode. Let's get back to the conversation with Pat. There's another thing that you mentioned that I want to follow up on. You mentioned that we've been waiting for psychiatry to prove some biological basis for a lot of these conditions, some sort of mechanism of action. And this is a kind of a perspective that a few colleagues of mine have pointed out to me, but a lot of, so for example, the pervasive use of SSRI medications, Prozac, Paxil, you can go on, Luvox, all the generic derivatives, et cetera, and there's a theory that of the blocking of the serotonin reuptake, et cetera, and there is some thought that is as scientifically found, grounded as gravity, and when in fact it's I've come to learn that that's not necessarily the case, that still remains a hypothesis, not necessarily a well-established theory. And I should just state, to be abundantly clear, that if you are taking any type of medication, do not change that based off of what you're hearing. Yeah. These two randos on the internet talking about, you want to make those decisions in context with, your care providers. So, and I also know that many people for whom SSRIs and other types of medications have been game changers as it relates to helping them access aspects of their lives that they weren't able to previously. So two huge caveats here, but getting back to the serotonin hypothesis here, is that your understanding as well, that it still remains a hypothesis and it hasn't been fully fleshed out in the experimental literature?
You're being kind to it by saying it hasn't been fully fleshed out. It's basically the chemical imbalance hypothesis. And it's nonsense on the face of it, because for something to be out of balance, we have to have a fine definition of what the balance is. That's not been established. I don't even know if there's a way to establish it. So it's sort of a non-empirical assumption that if a person is engaging in behavior that's consistent with, say, depression, then their serotonin mix must be out of whack or imbalanced. And all we need to do is balance it up by getting more serotonin into their system. So there's two things here. Getting more serotonin into a person's system is usually a good thing, but it doesn't imply that there was a deficit of serotonin to begin with. The other thing is that when you take these medications, they're not adding anything to your body. They're releasing what's already there. So there's lots of ways to release serotonin. When we get done here, I'm going to open up the blinds of my office, and there's a very good chance there's going to be a pair of mated geese sitting right outside my window. And when I look at them, I'll probably get a little spike of serotonin. If I were to walk around campus today, I'd get a little spike in serotonin. If I were to go over to our pond and look at the baby ducks that are going to be coming up, I get a little spike in serotonin. You complete an assignment, you get a little spike in serotonin. There's lots of ways to get more serotonin into your system. And one of those ways is to take an SSRI. But there are other ways that are more naturalistic, that don't require that you take anything, but they do require what you might call behavioral activation, behavioral performance, behavioral production. And I'm going to share the caveat with you, because I have clients that come to see me that are on SSRIs. I never try and talk them out of it. And if they're inclined to go and get a prescription for SSRIs, I don't try and talk them out of that either. I tell them what I just told you in some form. But I want people to be able to perform well in the world. There's another dimension of this, which is the placebo effect. And it's very real. If they believe that the medication they're taking is helping them, it almost certainly is, regardless of what it's composed of. And I don't want to mess with that belief. I want people to perform well in the world. And if there's something that I can offer that will help them do that, fine and good. If there's something they're already doing that helps them do that, that's fine and good too. A lot of ways to get home. Taking medication is one of them. Behavioral activation is another. The two combined is even another. But that chemical imbalance theory, I don't think any serious scientist in any of the mental health dimensions of the scientific world is subscribing to that theory anymore. That's been exposed for what it was in the beginning. But I get you. I mean, it's so, I don't know, credible on its face. It makes sense.
Yeah, it's got some face validity to it, I suppose.
Yeah. There's another one of those in the area of enuresis. There's a neurotransmitter, brain-based chemical that reduces or increases the consistency of urine during the night. Vasopressin is what it's called.
Yeah, DDAVP, yeah.
Well, that's the derivative of it. Yeah, that's the medicine. So the theory was that kids that are wetting the bed are deficient in the area of vasopressin. And so it made sense. I mean, that theory, it was a beautiful theory. And all we need to do is give them some variant of vasopressin, DDAVP. It'll result in the concentration of their urine throughout the night. So there's less of it. And they're less likely to wet the bed. Unfortunately, it was a beautiful theory, but in practice, it didn't really produce very good results. And the medication they were using to make that happen turned out to have some deadly side effects, which is the downside of medication. They almost always come with some kind of problematic side effect.
Got it. I appreciate you taking that little detour to our planned conversation because I think that's helpful. And again, do not change your medication regimen based off of this conversation, please.
Same thing. Do not change your medication.
We're talking about the science behind these things. And so anyway, all right. I want to get into the therapeutic process more deeply here, but I think it's worth talking about how to find a good therapist, how to determine if a therapist is a good fit, et cetera, et cetera. I know I've been aware of some data out there that sometimes it takes people like on average, like 2.5 to 3 times, they'll see an average of like 2.5 or 2.6 therapists before they find someone with whom they can gel with and whatnot. So I guess I have a broad question about how to find a therapist. Is therapist fit an actual important variable, or is it more important about what people do in therapy, the relationship, et cetera, et cetera? So can you speak at least initially more broadly about seeking help, if you will?
Probably the best way to find a good therapist is to learn about a good therapist from people that have one, and then question them about what they think about that therapist is good. What features does this therapist have that works well for the person that has that therapist, and decide whether or not those features would work well with you. A second, probably best way is, like, say, for example, if it's a set of parents and they want a therapist for their child, the safest person to ask is their child pediatrician. The pediatrician is a pragmatic professional. About 50% of all primary care pediatric visits involve behavior problems. That's the first stop for parents. And that pediatrician is arguably one of the most trusted professionals in the whole professional world. A good pediatrician almost becomes like a family member. And they want to maintain that status. So they kind of go through a number of different therapists they tried out and hit upon a couple that they trust. And they trust them for good reasons. And they can recommend a therapist to a family. An internist, a physician that works with adults, will do the same thing. I mean, they work with mental health problems a lot. They're usually the first prescription for SSRIs usually comes from an internist or a family practitioner, not from a psychiatrist. They'll usually give it one pass. They'll try one medication. If that doesn't work, then they'll refer the person to a psychiatrist. But the point of that is they work with mental health issues. And how likely you can ask that physician, you have somebody you'd recommend. So why not ask somebody that's already in therapy that you don't trust, find out why they're with that person. Secondly, ask your family physician, your primary care physician, your internist, what they would recommend. Barring that, good luck to you. It's a crapshoot. And the quality of training, the across the spectrum of all therapists and all psychologists is incredibly variable. And there are things that make a good therapist that I don't believe are trainable. You either have it or you don't. One of the things I'll say in here to people is if I recognize that a person if they're like you, frankly, if I have a sense that they are genuinely compassionate, they genuinely care, I'll look at them and go, you know what? You could be a therapist because that quality that you have, I can't train that. You either got it or you don't. You got it. The rest of this stuff I can train, but I can't train somebody to care. I can't train somebody to generate compassion for somebody that's outside their family. But if they have that tendency, which, Matt, I suspect you do, you should build around that. And not every therapist has that quality. And then there's the quality of their programs. Right now in the world of behavior analysis, there's a lot of variation in the quality of the training programs that are producing the ACBs. It's no different in psychology. There's some absolutely excellent programs. There's some absolutely excellent instructors at that one end of the continuum. There's a crowd at the other end of the continuum. So I feel like the quality control in the field of psychotherapy isn't even remotely close to the quality control that has been established for medicine. Maybe it will be one day, but it isn't now.
Well, I have to imagine that there's so many different routes to becoming a therapist. It's not, obviously people can go through a training program like yours, which the investment is off the charts to frankly do that, both in time and resources. You're devoting, almost a decade of your life when you add up all the schooling and things like that with your APA internships and.
Yeah. It takes a lot longer than it does to become a physician. You go to medical school, 4 years later, you're a doctor. You go to graduate school in psychology, 4 years later, you're 2/3 of the way through and you still have your internship.
Exactly. And so that reduces the population or the pool of licensed clinical psychologists who have, the so-called Boulder model, if you will, or whatever you want to call it, and then there's also other routes to becoming therapy. You could be an MSW, you could be a licensed clinical social worker. Sometimes the letters vary based off of what state you're in. And so there's a lot of, faster routes. And by faster, I'm not necessarily making a qualitative comment here, but, by faster, it would indicate, I guess less time trainings, of course. And I wonder if it's a similar model or a similar comparison to say, again, using your medical metaphor here, you've got a physician and then there's all these practitioners out there who are also providing primary care who might be physician's assistants or nurse practitioners and things like that, might not have gone to school for as long, et cetera, but are still out there providing care and so forth. So I don't know if you see that. Is that a worthwhile analogy pursuit to look at here? Or?
When I give a talk on, say, behavioral pediatrics, or inside of a talk that I've given, I talk about the application of behavior analysis to clinical problems in the mainstream population. When I'm done, people will come up and ask me what they should do. They think that sounds pretty good. I'd like to extend my practice beyond autism. I want to include autism, but I'd like to have other kinds of clients. How do I do that? And my advice is get a license or a certificate in some area. Become a licensed social worker, or a licensed mental health provider, whatever it takes in the state you're in. Get a license or a certificate that will allow you to bill third-party payers. You don't need a PhD for that. And bear in mind that the essence of my practice is skill development. Look, that's us. That's behavior analysis. If we're dealing with these illnesses, these psychic illnesses, well, you probably should have a specialized training for that. But if what you're working on is the development of a certain pattern of skills, in my view, behavior analysts are probably as good at that or as good at that as any professional, maybe better than most. It's just a matter of breaking the skill down into manageable steps and then teach you to do that. I don't think you need like 10 years of school.
What you do need is Chris McGinnis's new book on behavioral pediatrics.
You mean this book?
Yes, that book. There. Okay, Chris and I are going to sit down for an interview at some point or another. We're going to go deep on behavioral pediatrics. So, folks, I'll put a link to that in the show notes if you're listening along. You want to check it out. And anyway, so Chris, that one's for free, my friend. So anyway, so that's
in the forward. I think pretty much he is on just about everything you need to know to start a behavioral pediatric practice. Obviously, in the area of excellence, there's always more west to go, but to get one started, he's got information on every step you need to take in that book. And it's not a magnum opus. It's a small book, but it's packed with valuable information.
Hey, everyone, we're going to hop in and take another quick break right here. And I just want to remind you, in case you missed it at the beginning, that I've got a whole host of these behavioral observations episodes that are eligible for CEUs. We're over 50 events right now, if I'm not mistaken, across a wide range of topics, things like functional assessment and treatment, ethics, supervision, and lots more interesting things as well. So if you want to learn more about the CEUs that are available, go to behavioralobservations.com and click on the Get CEUs tab. And I should note that there are considerable discounts for multiple purchases, so there are opportunities to save a little bit when you're shopping over there. Again, that's behavioralobservations.com/get CEUs. All right, let's get back to the rest of this conversation with Pat. You know what's interesting is, I live in rural New England, and getting back to your earlier point about it being a world that's fraught with discomfort, if you will, whether it's anxiety, depression, or what have you, the wait lists for therapy are off the charts. It's unbelievable. And I also think that there's a dearth of providers particularly for men, and adolescent boys, and it's one of those things like I don't have designs on doing this, but if there was a practitioner out there that specialized in that with that population, you could fill a schedule Monday through Friday forever. It's unbelievable the need that's out there.
Well, I'm in a very large building, and there are 35 psychotherapists and psychologists in this building that work for me, and 4 of them are men. And so when a client calls in and asks for a man, we have to talk them into accepting someone else, or tell them how long it's going to be before they get in. But that's not confined to psychology. God forbid you should never have to do this. But if you need a pulmonologist, get your calendar out. You might not get in for months. In fact, you need a cardiologist in a rural part of the country. It could be months before you get to see the person.
Yeah.
So it's sort of medicine in general, not just mental health and psychology.
Okay.
But one of the things I'll tell people too is you don't need to declare yourself to be something to deliver services. Some of the words are protected. You can't call yourself a psychologist. You can't call yourself a psychotherapist. You can't call yourself a social worker. But you can call yourself a skill builder, and you can set on a shingle, and you can have people pay cash for services, and then you can work with them on the skill that you're specialized in developing. So in Nebraska, there's a woman, I can't remember what she calls herself. It's a cool name, but she's a thumb sucking expert. That's all she does. She just treats thumb sucking. And she's been doing it for 30 years. And she has an incredible amount of success. She's expensive, and she's a lovely person. There's a couple of people on the East Coast that do just sleep problems. They're sleep coaches. That's all. That's what they call themselves.
Oh, sure.
And they'll do home visits, and they do the same thing in their practice that a licensed psychologist specializing in sleep, like Connie Schnoes, who works for me, would do in practice. There's an organization called Pacific International. They have one product. You and I would call it dry bed training. They don't call it that, but fundamentally that's what it is. They co-opted Nate Azrin's approach to bedwetting, put in a little razzmatazz of their own, and then they sell it for $2,000 or $3,000 or $4,000. if I do a bedwetting case, it's a one visit deal. And what do we charge? Maybe $245. Never get to decide who's got the better idea here. So if a behavior analyst wants to break into those domains, they develop the skill, which would be much for them, establish, and then advertise. And if it would all be dependent upon how successful they can advertise themselves. I mean, a lot of ways to get home is what I'm saying.
Sure.
One of the ways is the conventional route. But to give you an idea about that, my advisors, my chairs were Don Baer, Montrose Wolf, and Todd Risley. So I got royalty. And I did it in order to get royalty. And so I got that behavior analytic training like no other. But that doesn't prepare a person to be licensed as a psychologist. Not even close. There were only 4 required courses because it was an apprenticeship model. So by day, I'm doing Baer, Wolf, and Risley. And by night, I was at a university called the University of Missouri in Kansas City, studying clinical psychology. So I'm doing parallel programs so that when I got done, I could be licensed as a psychologist. So you have to really double down sometimes to do it conventionally.
I see. All right. Let's move on to the therapeutic encounter, I guess the first visit. What does that look like? I assume there's some sort of assessment that's involved when someone comes through your door. How does that first conversation go?
For me, it's a little different, I think, than most. I have a highly specialized clientele. You can't see my office fully, but behind me is a door, and over to my right is a door. The door to my right is the door that people come in when they're in the building and they want to visit with me. The door behind me is where my clients come in. It's a private entrance because a significant percentage of my clients could be harmed politically or socially if it were known they were seeing a shrink. So my clients are what you might call the 1%. And I have my own early interview process. I do not take data. They're not going to sit still for that. Plus, I don't need to take data for the kinds of problems they present to me. And if you're watching me interview them and doing my assessment, and you were able to tell I was doing an assessment, I'm not doing it very well. So I just have a casual conversation with a client on an ongoing basis. It's very friendly and affirmative, and taking my time to ask questions that will reveal things about their history and things about their symptoms. The chances of me saying something like, so what seems to be the trouble? Or what's bothering you? That would be a bad day if I asked something like that. I'm going after the information I want very indirectly. And I'm much more interested in that conversation in places where the person is successful in their life. Not like successful in business, but where they successfully manage an irritation, a frustration, a fear, a depressive episode, and they got past it somehow. I want to explore stuff like that because there's an already existing set of skills there, in my view, that we want to amplify, pull forward, get it into the conversation, and then look for places to apply it where it hasn't been applied yet. And those places will be the symptoms of the things that brought them into my office. Am I making sense here?
Yeah. So,
very hard to spot. And I'm not recommending it for other people. I'm not saying that my way of doing therapy and my way of looking at therapeutic problems or psychiatric problems is the right way. Not at all. It's my way. I like to tell people about it just so they can hear about it, but I'm not telling them they should think that way or do that way.
Well, how do you train people then? Let's say you so if you have someone who's in your program and they're a mentee of yours, and so you just said that you've got a very, very distinct, very non-representative sample of clientele. Your mentee probably does not. So I guess I'm curious about the more modal type of what does that look like for that first interaction, and how do you teach people to do it? It might be a situation where it's like kind of like do as I say, not as I do, because of those characteristics that are pretty unique that you are practicing in, I suppose. So
you just summarized most of psychology in my view, which is do as I say, don't do as I do. Like there isn't any evidence that the average psychologist is any better at life than the average person on the street. The the depression statistics, the divorce statistics, the quality of life statistics, the anxiety statistics. There's no difference. There's no indication that they know anything more than the average person on the street. They know more than people in one tail of the distribution, but hey, who doesn't? And so they're very good at describing situations and what to do in those situations, but there isn't any evidence that they're any better at doing those things than anybody else.
Yeah, I guess the do as I say, not as I do is more related to the actual, kind of intake and first conversation characteristics. And I wasn't, and I'm not claiming hypocrisy or anything like that. I'm saying sounds like you've developed a unique style based off of the population that you serve. And if we're looking at more of a representative sample of people seeking treatment, how would you train someone to go through, to gather information in that first meeting?
Well, first and foremost, I don't have any mentees. I mean, my program has 6 postdoctoral fellows and 6 psychology interns, but none of them are my mentees. We decided quite a while ago that if I were to select 1 or 2 of them, the others would wonder why they weren't selected. And the way I do my practice scares, because they're coming out of programs with conventional training and they want to do a conventional interview. And they watch me do an interview and they can't even see it's happening. And they don't feel comfortable with something they can't take notes on and then put into practice easily. So I'll give you a more conventional approach. You meet the client, and then I would just say, okay, I have a few background questions I need to ask. Let's just get those out of the way. Is there anything about you medically that I should know? Any kind of condition like diabetes, or have you had recent surgery, or anything that's been done to your body that we should make part of our description of you? Have you ever seen a counselor before? Who and what did you see them for? How much education do you have? And where did you go to school for that education? What do you do for a living? How long have you done that job? Married? How long have you been married? Children? Can I know their names and ages? And this is an important question for Omaha, Nebraska. I don't know how it is for wherever you are. How important of a role does religion play in your life? And then I will ask some questions about their parish and whether or not they're going to instill those religious practices in their children, and how much agreement is there between them and their spouse about that religion, about how to teach the children. And then if we're working on a child, I get that information out of the way, and then I want to do a typical day interview. And what that means is I start at bedtime, and I just have them take me all the way around the clock. So we got to start at bedtime. What time is the bedtime? 8 o'clock. Okay, how do you get that accomplished? What are the steps you follow? And what kind of reaction do the kids have to your bedtime procedure? And then what about during the night? The kids stay in bed during the night, and they're out of bed, they wake you. And if so, how do you handle that? Tell me about the morning routine. Tell me about preparation for getting ready to school. Tell me about the ride to school. Can they come home at 3:30? What do they do right away when they get home? Okay. And then what do you have in place for homework? How much recreational time is there between getting home and dinner? What's dinner like? And how's the behavior at dinner? What's post-dinner like? What are the baths like? And who does it? Who's responsible? And then now we're back at bedtime again. And now that's a very, very abbreviated approach. That typical day interview, that could take easily an hour. Now, I'll do trainings on the typical day interview in front of my interns and postdocs and staff. And I'll bring in a live client and do a real one. And then the client will have to agree to let me annotate as we're doing it. I'm talking to the client. Okay, tell me about the morning routine. Woman will tell me this, that, and the other thing. I'll say, no, hang on a second. So do you see there what she just revealed about the morning routine? So in there is some tension. And she hit it reasonably well, but not completely. And you could tell she's a little frustrated about that aspect. And so you want to jot that down and come back to it, because that's going to be part of our clinical target. Okay, anyway, we're at the morning routine. Now we're getting ready for the car, like that.
So you break the fourth wall, if you will.
We break the fourth. Yes, exactly.
That's awesome. Yeah. I've used, versions of that type of interview, especially when doing, case consultation in schools. Often, whenever I can, I try to do a parent interview, and those type of day in the life type of conversations are very revealing and can tell you a lot about what's going on with a student, and points to various sources of reinforcement often. And so, yeah, I could see where that would be really helpful. And that's really gracious of the client who can sit and go through that with you. That's an incredible gift to the students to be able to share that experience that, probably reveals some, maybe potentially embarrassing characteristics or what have you. So yeah, that takes a big person to be able to do that. So that's cool that you're able to generate the trust necessary to have someone share that experience.
Well, there's more to it than that. I mean, the way I do it with them makes them feel and look terrific. I am as affirming as I can possibly be. I'm looking for areas of trouble, but I got like a 5 or 10 to 1 ratio of me finding stuff that they do well. I'll do the same thing. So when you put them in bed, you dim the lights and you take all their favorite toys and hide them from view. Why do you do that? Oh, because the toys get them excited and you want them to relax. Hang on one second. I'll turn to the crowd and go, do you see that? You see what she just does naturally? She got this natural ability to see what would be activating and what would be relaxing. And she's embedded it in her repertoire without any professional training. How many of you would be able to do like that? So on the front end, they might feel like I'm going to be revealing a lot of problematic stuff. But what ends up happening is what they're revealing is all the stuff they do exceptionally well. And then there's these little areas where they need some attention. Does that make sense?
It does. And it's reminiscent of most conversations I've had with you, just more generally, whether it's in an interview or spending some time together at a conference. You're very good at doing that and making people feel important and special or what have you. So that seems to be a generalized repertoire of yours. So how maybe I'm skipping to the end and maybe we can fill in the middle, but I'm curious in terms of the time course of a particular therapeutic intervention, so and maybe so through this conversation, it's revealing there's Pat's way of doing things given the characteristics of the clientele and years of practice, et so where that differs from the median or mode or whatever, certainly make those distinctions, please. But how, if someone comes in and they're experiencing anxiety, and let's say they're somewhere in the middle of those two poles that we described earlier, how long does treatment generally take? How long should it take? Are there, and is being in therapy for a lengthy periods of time, is that like a red flag, if you will? So can you talk about just the duration and intensity for a minute?
If it's a child, then it's a red flag. When I just did behavioral pediatrics, the average number of sessions was probably 6. Now, here's something on the other end of the continuum. A woman came to see me yesterday, and she's part of the upper echelon of society in Omaha. She was at a big dinner party, and somebody at that dinner party started talking about Dr. Pat. And she's listening to that. She goes, "Are you talking about Pat Friman?" The guy goes, "Yeah, he's great." She goes, "I've been seeing him. How long have you been seeing him?" 35 years. But I might see her once or twice a year. But what happened at that dinner party was 9 people that were at that dinner party all chimed in. So the joke was, okay, who here doesn't see Pat Friman? And I can't comment on any of this when somebody's telling me, I just smile
and nod.
I don't affirm or disconfirm. And after every session I ask, should I schedule you for another time? And they'll say, well, what do you think? And I'll say, I never recommend. I'm going to leave it entirely up to you. And if they say yes, then I always bring them back in. And if they say, well, let's hold off. And I'll say, you know what? I'll be sitting right by the phone. You can always call. Now, am I recommending that strategy, that tendency, that practice for others? Not on the front end. Should a beginning skater try a triple axel? I don't think so. And I've been doing it for so long that I can I have a lot of internal flexibility that allows me to be very creative and get back to conventional baseline easily. But a beginning therapist needs to establish conventional methods first. It's like Wittgenstein said, you want to master these ideas, and then you'll be up on a ladder. And once you get up to the top of that ladder, you kick it away. Now look at the world. And the ladder would be the conventional training that people go through, and you want to master that. And then you can kick it away and be more creative, more inventive. That's how I feel about behavior analytic training. The behavior analyst should master the conventional language of our field and all of its concepts, and so that they're very fluent, and then kick that away and start integrating what they know into ordinary language. You can always go back to the conventional approach if need be. But when they're with clients, they don't need the conventional approach. They need to be able to think that way and then translate that into how the client thinks. And that's kind of how I am with my clients. So that's why I say I've got my way, and I'm not necessarily saying people should use my way. I just want people to hear how I do it and hear what's possible. And that makes sense.
Yeah. So the client who comes back periodically, maybe once or twice a year, is the context of that like just kind of reminding what the skills they learned perhaps in their initial course of treatment? Hey, it looks like you are staying, you're avoiding this thing now, or tell me a little bit about how that might work, for someone coming in periodically. And I do want to get back to like the modal time course for a typical someone seeking treatment, perhaps with a therapist with less ability to improvise and in the way in which you've just described.
The person comes in initially because there's a problem, and they've tried to solve it themselves, and they didn't get anywhere. It's a relationship problem, or it's almost always a relationship of some sort. And they check with their friends about, is there anybody in town that you would trust who does mental health stuff? I got this issue. It gets me. And then we work on their problem. Inevitably, it gets much better. And they say, well, okay, we can I'll call you if I need you. Well, when would they call? Another problem has happened. And who do they know they can help with this problem that they can absolutely trust and never tell anybody about it? But there's only one person in their life who fits that bill, and that's me. I'm going to say this to you, Matt. I don't think you have anybody in your life that can keep a secret. Even your very best friends will do their best to keep a secret. But if you have a shrink, the shrink's got to keep the secret. So they got one person in their life, pretty good problem solver. They got now this new problem, and they want to go to that person and get some help solving this problem. So the woman I've been seeing for 35 years, she came in. What was her problem? She went on a rant about her 40-year-old daughter and how she parents. Her phone was open, and her daughter was on the other end of the line listening to the rant. It was just awful, just awful. And there's no taking it back. You can't go, I didn't mean it. And so she came in, and she wanted some instruction about how to manage her own feelings and how to manage the relationship that's now damaged with her daughter. And I hadn't seen her for like 9 months because, her life is on a pretty even keel. But it's like that. Something new happens. There's a trusted guy. We've seen him before. He didn't take very long to work with us. They give me a call.
Are you, I don't want to put you on the spot, but I guess the obvious question here is, what was the advice you gave her?
Well, first I'd ask a question. Did you say anything you don't believe? She goes, no, I knew the answer already. She's been bitching about her daughter for 20 years. Her daughter's irresponsible and her kids are spoiled. Her daughter, my client's son is a dentist. His sister, the daughter, called him for a favor, asked him to get her daughter into an orthodontist and get to the front of the line. He made it happen. She was a no-show. She calls again and asks for the same favor. He does it. Another no-show. So now those no-shows harm the son. And there's just a ton of that stuff that this daughter, I guess, perpetrates or exhibits. And so everything the mother said was absolutely true. And she believes it. And she's thinking, I'm not that kind of person. I'm going, yes, you are. you don't have that kind of image. You have an image of being a lovely, kind, gracious person. And this is inconsistent with your image. But you're not your image. You're much bigger than that. And this stuff that you said is stuff that your daughter really needed to do. That stuff you. When she gets over her anger, she's going to be looking at that content and going to benefit from it in some way, shape, or form. So it actually probably produced some good. Just on the front end, there's going to be a little bit of a pain. There was more to it than that, but that was one of the messages.
Okay. All right. That's, I just had to ask. I know people in the audience are like, oh my gosh, how'd that end up? Hey everyone, one more real quick break here. And I just want to let you know that if you want to get these episodes 100% ad free, go to patreon.com/behavioral observations. And you can sign up for a tier that works for you. And the biggest benefit of signing up for a Patreon subscription is that, again, you get these shows with no ads. I don't even do the preamble or anything like that. You just get the raw conversation. And that's it. I think that's probably one of the shortest ads we've got here in this episode. So let's get right back to the conclusion of my interview with Pat. I feel like we talked a lot about anxiety, and I want to maybe shift a little bit more towards depression. And what are some of the, what are some of the, I guess, signs someone's exhibiting a depression? What are the circumstances under which it becomes necessary or helpful or advantageous to seek therapy around it? And what are some of the strategies that you recommend therapists employ to help clients feel better with, be more successful, or however we might construe success in this context?
In terms of assessment, we're thinking threes. There's two sets of threes. One is cognitive, one is more behavioral. The behavioral dimension, and these are the most serious, are eating, sleeping, and activity. So if we're looking for clinically significant depression, then we want to look to see what's happened with eating. Most often, it's cut way back because they've lost their appetite. Sometimes it goes the other way. That's a small percentage of cases. Most people that have gotten depressed, say, for example, somebody broke up with them, they got rejected in a relationship, they lost their job, they have just got a bad diagnosis, or their mother just got a bad diagnosis. All of a sudden, they don't want to eat anymore. So they're starting to lose weight. Then sleeping. Almost always, it becomes excessive. Sometimes it becomes really constricted. But we want to look for an impact on eating and appetite. We want to look for an impact on sleeping, and then activities. What's been happening with stuff that the person does in their life that they really enjoy? Are they doing less of it or more of it? And they're always doing less. In fact, they don't even want to do any of it anymore if they're clinically depressed. So those are the behavioral dimensions. The cognitive dimensions are, it's me, it's going to last forever, and there's nothing I can do about it. So slowing that down, it's me. There's something wrong with me. It's going to last forever. There isn't anything I can do about this. What that generates is a sense of hopelessness. And that hopelessness is the core construct for depression. And so that's why they stop doing stuff. It's like, why bother? Not going to make any difference. Not going to get me anywhere.
What do you do about that?
Get them out of bed. Get them into the shower. Get some calories into their body. Get them out into the world so the sun can shine on them, basically. Because there's the distinction between the feeling of depression and being depressed. Having depressed feelings, like, adolescents will go depressed. But, they go to school, they go to football practice, they hang out with their friends in the alley and drink beer. That doesn't mean they're depressed. It means they have feelings of depression. If a person responds to those feelings with depressive actions, now we got a problem. So that's where we want to go to work. Did you read the Odyssey?
No.
Well, you know about Ulysses and Scylla and Charybdis and the sirens.
Yeah, I'm vaguely familiar with that, but that is not. My wife would be shaking her head at me right now because she's a high school English teacher and
high school education of yours.
Yeah.
The sirens run a rock outcropping. I guess they call that Scylla.
Yes.
Singing this seductive song to sailors as they sail by.
Yes.
Rock outcropping is a whirlpool called Charybdis. So they're luring men to their death with this seductive song. And Ulysses put wax in his men's ears so they couldn't hear the song, so they could sail on. forgot to put wax in his ear, so they had to lash him to the mast so he didn't steer the ship into Carbitis. Anyway, depression, in a metaphorical sense, is a siren, and it's luring people to bed. And it's telling them basically, you don't need anything in your life. You just need me. And we can go to bed. And that's all we're going to do. We don't need to eat. We don't need to take a shower. We don't need to take a bath. We don't have to go to work. We're just going to lay here. We're going to sleep as much as we can. If we do anything, we'll watch a little escapist TV. It's just me and you. And their life, it's just like agoraphobia. Their life shrinks all the way down to the bedroom. And it seems to them almost impossible to get out of that bedroom because depression is such a seductive siren. And so my job as a therapist is get them out of the bed, get them into clothes, or first get them into the shower, get them into clothes, get them out of that bedroom, get them out of that house and out into the world, whatever that takes. And if that takes an SSRI, I'm all over it. But that has to happen. And then we build on that. I mean, that's a oversimplification. There's a lot more to it than that.
Oh, of course. Yeah.
And then there's the therapeutic conversations that we have trying to do damage to the idea that, okay, it's you. Okay, there's something wrong with you. Point to it. It's going to last forever. When's the last time you heard that happen? Like, whatever. I mean, trying to do, I guess you might call it, I hate this term. I can hear Steve Higgins right now laughing at me. Cognitive reconstruction, which is just basically talking somebody out of something and into something else. That's part of it. But the most important part is the behavioral activity. Out of the bed, into the shower, into clothes, out of the apartment, out into the world, and into activity. Because you cannot be depressed and in action at the same time.
Got it.
You can be in action and have depressed feelings at the same time. But you can't be depressed and in action at the same time. They're opposite categories.
You know, Pat, as I was putting these questions together for you and just thinking about this topic more generally, I had this conclusion, and I want you to tell me if I'm off base or not, but it sounds like, you know, when you really boil cognitive behavioral therapy down to its essence, it's assisting people through, whether you want to call it a process of extinction or pushing through discomfort or what have you. And is that the fundamental core of what this work is that you're describing?
The central concept that runs through almost all psychopathology is what's called experiential avoidance, which yields negative reinforcement. And therapy, if it's effective, puts all the things that lead to that negative reinforcement on extinction. In effect, we're putting negative reinforcement on extinction. And we're trying to produce activities that will generate positive reinforcement.
Okay. Got it.
I phrased that well.
Okay. All right. And getting back to the picture of depression that you painted a minute ago of someone, you know, not leaving the house, staying in bed, I would be remiss if I didn't bring up the topic of social media as it relates to this. I know you're not on social media, and I think that's awesome. And don't go changing anytime soon. But that the ability to sit and scroll through these curated algorithms that send content to you to do all those things that you described earlier when you're talking about the news, you know, but now I think it's that on steroids insofar that, you know, you can get on Instagram and scroll through these little short movies that are, they're, and a lot of these things aren't necessarily agitating per se. They're actually quite funny, or they have other types of, you know, what you might consider sensory reinforcing process, you know, properties, if you will. And that adds another layer of dimension. And then the social component in terms of comparison and things like that. There is some, I think was it Jonathan Haidt? I just wrote you know, he's done a lot of writing. It's either Jonathan Haidt or Greg Lukianoff. I can't remember who, but they wrote like The Coddling of the American Mind. And they just came out with a book called The Anxious Generation. And they lay a lot of this stuff at the feet of social media, not necessarily that social media is the cause of this sort of thing, but it's certainly thrown gas on the fire, if you will, of the seemingly gigantic increase in mental health distress, particularly amongst adolescents and young adults. Do you have an opinion on that? I guess is my broad question.
There's so many dimensions to this that are problematic for people. One is the stuff that people are looking at isn't necessarily all bad news. They could be looking at entertaining, YouTube videos or little vignettes from TikTok.
Oh yeah, it's like puppies and cats and people, doing silly things with bicycles or crashing into things or what. I mean, it runs the gamut and it feeds stuff that's interesting to you, or maybe cooking. I spend an embarrassing amount of time watching people like cook stuff.
Well, what it is in my view, metaphorically speaking, is recreational, highly processed fast food. And when you gorge on like a big bag of Cheetos, for example, you're enjoying it while you're eating them. But when you're done, you don't feel too good.
Yeah, you phased out there for a second, but you're back. Yeah, go ahead. So it's like, so just to kind of, so you're saying it's like eating fast food. Go.
Yeah, it's like recreational fast food. And when you gorge on fast food, it's great while you're doing it. When you're done, you don't feel so good. And when you gorge on that recreational fast food with video vignettes, you realize you haven't accomplished a damn thing while you've been doing that. And it doesn't feel that good. It's not, it's maybe inherently rewarding while you're doing it, but ultimately it's punishing and has a person feel like they've wasted their time. And maybe even worse, like they don't have the self-control they wish they had. And it ate into the time they needed to do other things. And that's probably as good as it gets. Then there's FOMO, stuff that you're not part of and you want to be and wish you were. And then there's all the bad news. Yeah. It doesn't mean that there isn't some good stuff. Like there's a series of YouTube videos on something called VHR, variable heart rate. And I'll watch those because I can learn practices that I can engage in order to increase my variable heart rate. For example, now this is all the rage, but every day I take a 5-minute freezing cold shower, cold as I can get the water, and I stay under it for 5 minutes. Initially, I hated it. Now I love it, and I miss it when I don't do it. I never would have thought of that on my own. I do box breathing. I learned about that from Andrew Hooper. I have a particular kind of meditation that I'll do, and I learned it online how to do that. Like, there's some good stuff there. But I don't think that's what you're talking about. I don't think you're talking about people that are going on social media in order to learn how to improve their life.
Correct. Yeah.
If they're doing it, I think that would be a good thing because there's a lot of information out there that's useful. But that's not what you're talking. You're talking about time wasting.
That's a perfect segue to what I wanted to ask you next. Going online to learn how to improve your life. There's two dimensions of this that I want to explore with you. One is perhaps a longer standing medium of self-help, which is, the self-help workbooks, the section of Barnes and Nobles. And I went to, them just, back in the day when people used to go to bookstores. I'm thinking of workbooks like Get Out of Your Mind and Into Your Life by Steve Hayes and colleagues. But also, I can't go 5 minutes on television without seeing a BetterHelp or some other type of online therapy commercial where so I'm just curious, does the field of clinical psychology have any outcome data as it relates to these sorts of perhaps, DIY or do on your, some other type of non-direct interaction type of therapeutic modalities?
I believe they do. I think I've seen small accounts suggesting that there's a handful of studies that suggest like virtual therapy or canned therapies that are done virtually can have a beneficial effect. I'm not as confident in the kinds of experimental assessments that are done for clinical psychology interventions as I guess I once was. I think that there's a lot of confirmation bias that occurs in that kind of study. It's not like the authors of the study are being dishonest. And sometimes the questions are phrased in a way or posed in a way that almost leads to a successful outcome. So I can't imagine that they'd be harmful. And it does seem easy to imagine they could be at least mildly helpful. That red flag for me is anything that has the word therapy in it, because then there's the implicit message that you're sick. And I just don't buy it. I'm not saying there's no such thing as mental illness. I just read an account of the very first mass shooter, 15-year-old kid that occurred before Columbine. And the kid was hearing command hallucinations and following the instructions that he was hearing in his head. That's not a skill deficit, but that's rare. I think real psychopathology, whatever that is real, It's real, but it's rare. And there's nothing subtle about it. We have in this building, we have this kind of shorthand, which is, I saw an ADHD kid today. He's a real one. Most of the kids we see, they don't really fit that category very well. But a real kid, a kid's trying to sit on his mom's lap and she's standing up. I mean, it's like so obvious. Kid's bonkers. And just across the spectrum, like a real classic case of something almost defies explanation. But the average case doesn't. And that's mostly what we're talking about. The nice thing about the online stuff is access. Doing that better than doing nothing. At least you got them thinking about some things. They get some ideas about different practices they can engage in. They're hearing an affirming comment or two that they wouldn't otherwise hear. They're getting a better idea about themselves than they otherwise would get. It seems like that's probably substantially better than just being in your head waiting 6 months to get in to see a therapist. On the whole, probably better than nothing.
Got it. Well, this has been really fun. I just have a couple more questions for you, Pat, and I appreciate you being so generous with your time this morning. I think in one of our first conversations, you mentioned that you prefer to hire people who have maybe a touch of anxiety. Is that still the case? And then beyond that, I want you to perhaps, if there's anything else about this topic that I haven't thought to ask, feel free to conclude with any other remarks.
It's a little bit of a balance in hiring people that are a little bit anxious, because it doesn't take much to be too anxious. I want my staff, my psychological staff, to be better at life than the person in front of them. So if they're so anxious that there's stuff that they just can't do or won't do, and their client has the same thing, I don't know where they're going to go with that. Do as I say, don't do as I do, or whatever that is. But if you have somebody that's a little bit anxious, you don't have to check on them. They check on themselves. Right? I'm married to a laid back person, and I like that. We're balanced. I'm a little anxious myself. So which of us do you think is going to make sure the garage door is closed when we go on vacation? That's me. And periodically I'll come home, the garage door will be open, and Holly's not there. So a little anxiety is beneficial. What was the other part of that question?
Oh, I was just going to give you the opportunity. If there's anything else on the topic of therapy that you want to conclude with, just want to give you the last word.
Okay, well, there's something for your behavior analytic audience, because there's something that their clients are guaranteed to receive when the two get together. But it isn't, I think, attended to by the behavior analyst. I don't think they know they're doing it. And I don't think they know the benefit of doing it. And what that is it's some version of, like a composite of kindness and acceptance. Like, their clients are guaranteed to access kindness and acceptance at every appointment. Then the question is, where else in the life of that person are they guaranteed to receive kindness and acceptance for up to an hour? And for a lot of people, nowhere. So that's not nothing. That's something. And when you're kind to a human being and you're accepting to a human being, it's experienced as such. And that means it becomes part of their neurology, part of their experiential makeup. In other words, it doesn't leak out the back. It's part of them now. And it can always be accessed at any time. I mean, it might sink beneath awareness and not surface for 10 years. And then the person, I remember Matt. This guy named Matt. I just came into the building one morning and I was having a terrible day. And I looked up and there's Matt, and he's smiling at me and he gave me a big hug. And God, that made a huge difference in my day that day. And I just thought of that just now. That could be 10 years down the road. And what I want behavior analysts to know is that they're doing that even if they don't know they're doing it. And they're benefiting people, even if the benefit isn't obviously manifested in real time. And I think they should keep their attention on their desire to do good in the world, which brought them to the profession that they're in. And by showing up in a session, they are doing good in the world, even if their program isn't going anywhere. There, that's the last word.
Can't think of better words to end on. Pat, thanks so much for joining me today.
Yeah, thanks for having me. I really appreciate it. I appreciate the program too. I know everybody else does as well.
Thank you.
Thank you for listening to the Behavioral Observations podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.